Right. Hi, everyone. This is your Exam 1 study guide video. And I'm just going to be going through the study guide and hopefully this helps you study for the exams. Like I said, exams are going to be 25 questions, 2 points apiece, all multiple choice, no short answer, so you shouldn't have any issues there. So let's go ahead and start with communication in public health or health communication in public health. So make sure you know the definition using from the slides that it's research, theory, practice related, understanding and influencing the interdependence of communication and health related beliefs, behaviors, and outcomes. So basically with this definition, which it's put right in the study guide for you, um, health communication and public health are so interdependent upon one another that you can't have one without the other, really. So it's all based in research that is conducted by public health officials, health communication specialists, and the communication is also dependent on the health related beliefs, the behaviors, and the outcomes. So what are people believing about health? How are they acting toward health? And the outcomes of those actions. So let's talk about the coronavirus vaccine for just a second. What have you seen in the media about it? What have we heard people say about it? That impacts how we feel about it. And I am fully vaccinated. I've gotten both shots well over 2 weeks ago. So my personal belief about it is that science is good, that this is a good thing. People are going to sorry, I think I'm actually getting kind of a cold. People are actually going to be better off getting it. And so that influences my behavior because I went and got the vaccine. I tell people that I think personally they should get the vaccine, and then the outcomes. So when I got the vaccine, for a day after the second dose, I felt really crappy. But overall, I feel better. I do still wear my mask in public because I don't know other people. I don't know their status. I'm not going to ask them their status, but I'm going to keep myself safe because I do have kind of a compromised immune system. So they're all interrelated based on the research that we have seen be put out by, like I said, public health officials and health communication specialists. Moving forward to the biomedical and biopsychosocial model. So biomedical model is all about you see the illness and you fix that area, right? So you break your arm, you go to the doctor does a test, says, yeah, it's broken, they might do some scans, and then they put you in a cast. With biopsychosocial, it's all about the illness and the social aspect of it. So we take into consideration like, okay, where are you hurting? How are you feeling about this? And how does that impact your social well-being? So make sure you know the difference between those two. Let's see, I'm going to pull something. I'm going to pull this over here. With patient-centered communication, know what it entails. So with patient-centered communication, it's all about getting the patient the help that they need, meeting them at their level, making sure that they feel comfortable talking to you, that as a provider, not necessarily you, but talking to a provider. And sorry, I'm like losing my track of words that I want to say. Not only that they feel comfortable, but that they can communicate what's going on. So the provider isn't talking over or interrupting. The provider doesn't use words that the patient doesn't understand. The functions include trust, information exchange, messaging, or not messaging, oh my gosh, managing uncertainty, navigating emotions, and promoting self-management. So the patient trusts the provider. They are exchanging information at rates where both parties can understand what's going on. The doctor, the provider, whoever isn't using jargon that is going to be too complex for the patient to understand. They manage uncertainty. Just a quick little example of this. When I asked about the vaccine, I said, what are the side effects or the symptoms I might experience? And my doctor told me, you might have a headache, you might get chills, you might run a fever, but usually these symptoms last about 24 hours. And he was right. So my uncertainty was managed because I felt better equipped to understand what was going to happen to me in the following day or days after getting the vaccine. Navigating emotions. There are some topics that are really heavy topics, you know, if it's a cancer diagnosis, that you help navigate those emotions in a positive way or as positive as you can be, but you also validate those emotions. And then promoting self management. So patients can go home, they know exactly what to do. They don't have any questions, but should they have any questions, they could call back in, that um, they can continue to do their regimen once they're at home. So what does relationship centered care add to patient centered care? Basically, the patient feels as though they are important. They're not just another number, they're not just another chart, they're not just another face that the doctor sees for 5 minutes. You feel as though your relationship is valued and it's important. And you value that relationship as a patient as well. Think back to maybe your primary care physician. I know for me, back in my hometown of Illinois, we only had one doctor. Him and I got along really great. He would joke around with me. I felt comfortable with him. I could talk to him about things without any repercussions. But here in Morgantown, there's a lot of doctors to choose from. And it took me quite a while to find one. And I ended up working with Dr. Graves, and he was fantastic. I felt like I was talking to my doctor back home, and we felt really comfortable with each other. I'm sorry, you can probably hear the sirens. Our house just has very thin walls, so I do apologize for that. Um, Know and be able to apply the concepts from communication accommodation theory, so CAT. So accommodation means you are changing your speech. This could be as simple as, you know, matching regional dialects, but it could be changing your communication in a way that you're not using jargon. There are some patients that um, you know, don't understand. We know that most uh, most research suggests that people read between a fifth and a seventh grade level, but we know that education materials and health materials are also written at a 12th grade level and sometimes even above that. There are several articles I read throughout my PhD where I did not understand some of the things that were going on, and I had to do a lot of outside research just to read the article. So we accommodate our communication to match the other person. So I might explain things in a way that a fifth grader to a seventh grader would be able to understand. I'm not trying to dumb it down, but it's where we're at research wise. And it's now suggested after the pandemic that people are actually reading at like a third to a fourth grade level because so many young adults missed out on so much from that last year. And that's not totally supported. We need a couple more years to see, but that's kind of the consensus. Difference between divergence and convergence. Divergence means that you are different, so you diverge. So in academics, we're always told when we get a PhD, especially if we're younger, like I'm only 28 right now, that we should introduce ourselves as Dr. Wilson, which is why I always sign my emails for the form emails for the entire class as Dr. Wilson, right? To separate. Not that I think I'm better than you, not that I even really like doing that, but it separates student from professor. Convergence means that you come together, you find your similarities. So again, this is an academic setting, not necessarily health, but it works with health as well. You start finding common ground. So I always talked about my student athletes or being in clubs. When I was an undergrad, I was involved in so many different clubs, and I would ask students, is anybody in Greek life or is anybody in a sport? And I always made it a note that I can connect with all these different students based on different things and common ground that we all share. Okay. Over accommodation means that you are accommodating, but you're doing it too much. So think about when you talk to your grandparents. We often over accommodate for them because we think old age, hard of hearing, less competent, they're not going to understand. So when we're talking to grandma, we might talk loud or slow because we think that grandma's not going to understand. And it's not that they're stupid, it's not that they don't understand. Sometimes they need a little bit further explaining, but we don't need to over accommodate. There was an interesting study on over accommodation that there was this interesting study where I'm sorry, I was like losing my train of thought. They asked foreign exchange students to ask a group of American students or students who appeared to be from America for directions to, I think it was the student union. And what they found was they would just say, "Can you tell me how to get to the student union?" And they would say it normal. And the student would give these directions, you go down the hill, you turn left, then you have to go down another hill and go through the tunnel, and you'll be at a stairwell, take that stair up, or the elevator if you need it, and then you'll be right at the union or the student union lobby, right? Something like that. But when the foreign exchange student said that they didn't understand, they slowed their speech down, they talked a little bit louder, but they gave the same exact directions. And so it really was an over accommodation, not changing communication. So from the readings, the page numbers are in there. So think about like closed-ended responses. So if it's a yes, no question, it's a closed-ended. Do you have pain in your arm? Yes or no, right? If it's open, it might say, okay, you said you have pain in your arm. Tell me about this pain, right? So you're furthering the conversation. I heard you already have pain in your arm, and you might start with a closed ended and then move to an open ended. But I heard you have pain in your arm. Tell me about this. Furthering the information where there's not a bubble a person could fill in for their answer. They would have to physically say or write something down. I don't have my book on me right now. So see page 75, or 77, I'm sorry, for the recommendations made from the book on how doctors think for patients helping their providers communicate. It's page 77. There's 5 recommendations. They are in italics in the book, and know what effects that these have on providers. Know how they change the provider's communication. Know how they impact that relationship. Okay? And then again, I don't have my book, I apologize. It's page 101 for the empathy after medical training. So know, does empathy increase, decrease? Is it unaffected during medical school? Does it change after their training is over? The written portion, you're not gonna have to write anything down, but it's good to just go through and maybe have an idea. You might see a short answer question or a multiple choice answer. Um, like I said, we do read at a 5th to 7th grade level, but most things are written at a 12th grade level. Know what the primary focus when examining the communication between health providers and patients. Know what should be the primary focus. Understand mind-body dualism, the Western medicine views, and that was kind of talked about with the biomedical and biopsychosocials. So disease is the physical condition, illness is how it's experienced. So I have blood clots, but my experience is I took blood thinners, I was okay, I've got a chronic one in my leg, but that's my experience. There are other people who are not so lucky. Understand what a health disparity is. So it's differences in health outcomes between 2 groups of people. So oftentimes we study this with race. So understanding how a health disparity might be instituted for people of color versus white people. Talked about accommodation. Understand health literacy. So what is health literacy? It's the ability to access, understand, and use health information to make health decisions. So we have to be able to know where to go to get this information. We have to know how to understand it. What does this mean? And then how do we use that information to make the further decision? No patient empowerment. So they have the ability and confidence to take control of their needs. Um, we talked about relationship centeredness, and patients are more likely to feel satisfied and they follow through with their providers and recommendations when they feel like they have this relationship. Talking about cost effectiveness, so understand the cost effectiveness and efficiency. It's most cost effective and efficient to prevent diseases rather than treat diseases. So going in for cancer screenings, um, you know, getting those screenings yearly, 3 years, whatever it is for your age group. Talked about the biopsychosocial approach. Uh, Understand cultural sensitivity and the approach to health communication that assumes disparities come from health messages being culturally misunderstood. So, depending on your culture, a message might be completely misunderstood because it doesn't happen in your culture or your culture doesn't have anything like that. Patient empowerment. So, patient empowerment is patients have the ability and confidence to take control of their health needs. So, making sure that patients are empowered, they can go home and take care of themselves with the rules and regulations of their regimen. Understand why doctors interrupting can be problematic. Oftentimes, it makes people stop talking and they won't explain their problems further. Understand stereotype threat, which is the perceived risk of confirming a negative stereotype about the social group that you belong to. Um, with this stereotype threat, um, think about it like this. I'm trying to think. There was a study I read, and they had a bunch of white males who were going to take a math exam, and they said their scores would be compared to the Asian males. That automatically made the white males perform worse because they have this stereotype that the Asian community is better at math, so I'm not going to do as well. So why would I even try? Talked about health literacy. So understand ethnocentrism um, and labeling of therapies as alternative medicine or complementary medicine and how it reflects ethnocentrisms in which way. So this basically implies that Western medicine is superior to any form. We think that we have the best types of medicine. They are far superior. They get better results. And sometimes there are alternative medicines or complementary medicines that do the trick just as well, if not better. Think about like acupuncture. That's not a Western medicine. That's more of an Eastern holistic style healing. And it does help a lot. Talked about over accommodation. So in the bias in medicine video that was linked in the slides, we see pitfalls taking cultural competencies, approaches to medicine, and they're shown in which a way that racial groups are assumed to accept more pain or make up answers to numeric scales. And this basically means that we think that people of color are basically going to lie to us. They can take more pain. It was found that medical students, actual medical students, thought that people of color and white people handled pain differently. And that's just not true, just based on their ethnicity or race. There was a story in that video that people, women of color who were giving birth were not given drugs to ease the pain because they were going to take them and sell them. That was an idea. Somebody was, one woman, might have been Regina King. I think she said that. She was given Tylenol after she gave birth. Like, that's insane. Asking questions, make sure you know that asking questions can stimulate providers' thinking as well as patients, so coming from both sides. culture-centered approach to health communication assumes that culture is dynamic and that health disparities result from structural disadvantages and equal access to care. The public not viewing risky behaviors as dangerous as experts do comes from public and experts having different vantage points or perspectives. So, experts obviously have all the training, the tools necessary, the skills, whereas the public doesn't. And they view things differently, but that's because the experts have a vantage point. Um, think of framing, so gain framing or loss framing. Um, and with this one, understanding that, you know, gain framing helps student or not students, helps people gain something from doing the behavior. Loss framing means that you are losing something from the behavior. So if I continue to smoke, I might lose my life. If I quit smoking, I can live long enough to see my kids become parents, things like that. Um, Cultural competence, it reduces a given culture can be, yeah, it reduces a given culture can be distilled in some list of things to learn, separates a culture from lived reality that fundamentally shapes it. It ignores larger structural social or structural societal forces for the amount of health disparities. So these are why we should be cautious of cultural competence. And we talked about that early on in the summer session. And in class, we've also talked about reasons why patients experience low health literacy and they don't engage with their providers, was that they feared being stigmatized. So know how our textbook defines stigma and what does it mean? So it means that people fear social rejection and feeling dishonorable. Okay. So those are everything that you need to know for the exam. If you have any questions over it, please don't hesitate to reach out. I'd be happy to help in any way. All right. Have a good day. Thanks.